My name is Kelly Pratt, and I am thankful for Claude inviting me to discuss a topic for this channel. He specifically requests for chronic kidney disease. So knowing a little bit of background on this, I thought, well, this would be a good thing to share with nurses, nursing students, as well as patients. So a little bit about me. I graduated in 2007 with my master's in education, nursing education. That was my first love. I wanted to teach nursing. While I was working towards that degree, I was a diabetes and nutrition educator. So I was working specifically in diabetes, and I realized that I can teach my patients many things, but if I can't manage the medication side, I was at a disadvantage. So I went on and got my nurse practitioner in 2009. So in America, nurse practitioners can prescribe medications. So that rounded out my ability to manage diabetes better. It wasn't just about the education piece, but it was also about the prescribing piece. I stayed in diabetes for 2 more years, and then got married and had babies, and we went to South Korea where I taught nursing, stepped back into the education role, transitioned to Rwanda, taught nursing there. It was a very, very wonderful experience in both of those countries. In 2018, we decided to come back to America, and I got a job at the Kidney and Hypertension Center here in Grand Forks, North Dakota. So I was doing primary care. I was managing many different things, but the initial focus was chronic kidney disease, acute kidney disease, dialysis patients, and then all of the different disease processes that feed into that, such as diabetes. So we will definitely touch on that. But I worked for that entity for 4 years. And then I started my own clinic called Kindle Wellness. Currently, in my own clinic, I'm not doing as much of the traditional medicine, the traditional primary care. I am doing more holistic medicine, hormone optimization, just changed my focus a little bit because I'm on my own. So that's a little bit of background and where I'm coming from to talk about chronic kidney disease. So just a quick review on the basic anatomy. God blessed us with 2 kidneys. We actually only need 1 kidney to survive, and many people only have 1 kidney. But we're traditionally born with 2 kidneys. Those kidneys are filtering blood and dealing with the waste that our body produces. That waste comes down the ureters into the bladder and then out the urethra as urine. So think of our kidneys as a basic filter, that it's filtering all of the bad things and keeping the good things, and the bad things come out as our urine. A very basic anatomy. But as we talk about different kidney diseases, and whether we're talking about pre-renal disease, so that happens above the kidneys, or whether we're talking about post-renal issues happening below the kidneys. So we'll dive in a little bit deeper, but just as this big overview looking at our basic anatomy: 2 kidneys, ureters, bladder, and then that drains the urethra out of the body. Next slide. So urinary elimination, many times when I'm talking to my patients, I will ask them, tell me what your urine looks like. So I appreciate this picture. As you're looking at your screen, you can see very, very light colored urine that is very dilute, all the way down trending to very, very dark and concentrated urine. So the even just the color of the urine, without sending urine to a lab, we can still get a very good picture about how this person is doing hydration wise. When we do send urine to the lab, a report will come back and it will tell us the color. It will tell us, is it clear? Is it cloudy? Can we see through it? The specific gravity, many nurses don't understand the specific gravity when they're reading a lab report. That talks about the concentration of the urine. So a higher specific gravity tells me that you are more dry, you are more dehydrated. A lower specific gravity, you are very hydrated and your urine is not very concentrated. Generally, in a 24-hour period, we're producing between 1 and 2 liters of urine. That would be an appropriate amount of urine traditionally for a healthy person. We're not just looking at the urine, though, when we're talking about kidney disease. We're also looking at blood changes, because remember, the blood filters and we get urine. So if we have more waste in the blood, we're going to see elevations in the BUN or the creatinine level, or both. If we're seeing higher levels, that's an indicator that we have more waste and that our kidneys are not doing a good enough job filtering that waste. So in the perfect world, we want very low levels of BUN and creatinine. So some basic definitions. Sometimes nursing students will hear these, doctors will throw these out. So it's just a good idea to review. Anuria is very little output, less than 100 milliliters in 24 hours. That would be what we would see in a dialysis patient, that their kidneys are not working at all. They are still urinating, but very, very little bit. 400. So they're urinating even more, but it's still very, very little. Polyuria, poly meaning many urine. We see this with diabetes. We see this with some pituitary tumors. We see people urinating just copious, much. And that is a problem as well. Dysuria, meaning painful, uria meaning urination. So painful voiding, painful urination. We'll see this if somebody has a urinary tract infection. They'll complain about burning sensation, or it hurts to urinate. E-ureus, this is bedwetting in a child that's at least 5 years old. So this is not normal. We definitely want to address this bedwetting in a child over 5 years old. Kidney stones. So the technical name for kidney stones, nephrolithiasis. That's if the stone is in the actual kidney region. Urolithiasis is a stone in the ureters. So depending on where it is, different definitions, but understanding that they're both calculi, they're both stones, and I've got a picture later on showing different kidney stones. If anybody has passed one of those, oftentimes we will measure it, analyze it to see what is the component of that kidney stone, because we want to prevent these in the future. They're very damaging to the kidneys. Predisposing factors for chronic kidney disease. So chronic kidney disease, we often call this, and many diseases we'll see and talk about being silent, that there are not a lot of symptoms of chronic kidney disease. It is chronic for a reason. It is long-standing. We often do not have symptoms of chronic kidney disease. Our kidneys just slowly start to fail, and it's not until we're really struggling with kidney function that we'll start to have some symptoms. But some predisposing factors. So as nurses, as family members that might be caring for elderly parents or other people, these are some things to be watching out for that might make us more likely to have chronic kidney disease. Bed rest. We are made to move. God created us to move. And so very few times is bed rest a good thing. Tumors, cancer, especially if they're in the kidney area or in the bladder or in the ureters, all of those things can cause resulting chronic kidney disease. Prostate enlargement. So I have a picture later on talking about how that prostate and positioning around the urethra and how that can lead to chronic kidney disease. Decreased bladder tone. So if we have an elderly person that's had a urinary catheter in for a long period of time, that is definitely a risk for infection, a risk for bladder tone issues. Are we going to be able to empty well? That's a predisposing factor. Childbirth, many times as nurses, that's one of the first things after a woman delivers a baby. We want to make sure they urinate. There's a lot of swelling, a lot of tissue changes in that vaginal canal. Is she able to urinate, or is that urethra being blocked off? Neurogenic, different causes. If somebody's had a stroke or if they've had a spinal injury that might be affecting their ability to empty their bladder, that definitely is a predisposing factor. Calculi or stones. If you have recurrent kidney stones, it will definitely hurt your kidneys over the long run. Stress of any kind, whether it is a physical stress, whether it is an emotional stress, the body always keeps the cards and keeps track of that. And urinary tract infections, this is probably one of the biggest things that I saw in my practice was young women that had recurrent urinary tract infections. The kidneys are very, very resilient and they can repair themselves, but there's only so many assaults, so many damages that can happen, and ultimately those kidneys will start to not recover as well. How do we prevent chronic kidney disease? I cannot stress the hydration enough. And when I lived in Rwanda, we had a water challenge with my students, pushing them to drink 3 and 4 liters a day, because I think not just in Africa, very much in America, very much in Europe, all over the world, I think we run a chronically dehydrated body. And when we think about how much water our body uses on a daily basis, how much we are just made up of water, the fact that we're drinking coffee or soda or tea, or like we can be drinking so many things, but if it's dehydrating us and it's not hydrating us, what is that doing in the long run? So at least 1.5 liters to 2 liters a day, at least. But that all needs to be taken into a perspective, because if you're outside and it's very, very hot and you're sweating, or if you're exercising really hard and you're losing a lot of water with your respirations, 2 liters is not going to be enough. So many times with my patients, I talk about, what does your urine look like? What does your urine look like? And if your urine is more dark on that continuum, if it's more dark and concentrated, you are not drinking enough. You are not replacing what you're losing. Think about your patients that have diarrhea or nausea and vomiting, and they're losing fluid that way as well. That 2 liters is not enough. So it really has to play into what's going on in the body at that moment. But fluid. Voiding habits is another specific thing for prevention of chronic kidney disease. Your voiding habits, are you urinating appropriately? We should be urinating 5 and 6 times a day. If we're not urinating that often, then we're not hydrated. We're not filtering out the waste in our body. So I come back around to fluid as being such a vital piece of how these kidneys work and how we prevent damage in the long run. So these are pictures of kidney stones. If anyone has had a kidney stone, I personally have not, but I have had patients that tell me, Kelly, it is worse than labor and delivery. It is worse than post-surgical pain. The pain that goes with kidney stones is very, very significant. And you can see in the picture, some of these stones are very, very large. Some of them are jagged and rough on the edges. And yes, if that kidney stone just sits in your kidney and doesn't move, it's no problem. You don't even know it's there. But if it starts moving and causing inflammation, it can be very, very painful. The symptoms of renal colic is severe pain. These people are not complaining, I have a little backache. No. These people are significantly sick. They are presenting to the emergency department. They are significantly sick. They are sweating, nauseous, vomiting, fever. They will likely have blood in their urine, gross hematuria that you even see when they urinate. It's very, very significant. The causes of kidney stones or ureter stones is urinary stasis. So they're dehydrated. That urine is not flowing and getting rid of the waste. Hypercalcemia, so high levels of calcium. People that are taking calcium supplements. Again, people that aren't drinking enough to filter that calcium out. Dehydration, gout, uric acid is a very, very common cause of kidney stones. We get elevated uric acid from soda, from red meat, from alcohol consumption. We can get high oxalates if we're consuming a lot of those products and then not drinking enough. How do we diagnose them? We can do renal ultrasound. That's the cheapest way to do it, or we can do a CT scan. And then treatment. How do we get rid of that stone? Sometimes we will do surgery and go in and try to collect that stone out. Sometimes we'll put a stent in so that you can pass that stone easier. Antibiotics if we're dealing with an infection, but hydration is a big key as well. So here's a picture of a prostate enlargement. So BPH, benign prostate hypertrophy, which is just an enlargement of that prostate tissue. You see in the picture on the left, the prostate that surrounds the urethra. The urethra drains the bladder down out to the outside of the body. If we've got some swelling in that prostate gland acts like a tourniquet and it squeezes that urethra. And so people are not able to void well. So I have a patient that came to me and he says, Kelly, I'm losing weight and I'm not really trying to. I feel okay. He didn't have any overt signs of anything hugely wrong with him, but I'm losing weight. And I looked back in his record and I said, we haven't done labs in over a year. Let's just check some labs and see and I was not expecting to find anything hugely wrong. He looked healthy. His weight was okay. He was exercising more. I just chalked it up to this is just how we are today. His labs started coming back. He saw me in the morning and he went immediately to get his labs, and they started coming back to my computer by that afternoon. And I truly thought that the lab had messed up the patient identification because his creatinine was very, very high. His kidney function was very, very low. And I thought, this is not the patient that was sitting in front of me this morning. It just doesn't mesh. It doesn't match. So I didn't do anything. I waited for all of the labs to come back. I didn't just want to look at a few of the labs. I waited for them all to come back. So his BUN was elevated, his creatinine was elevated, his hemoglobin, looking at anemia, was very, very low. So by the end of the day, I called him and I said, I've gotten the majority of your labs back and I'm very concerned about your kidney function. We need to do some more testing to see if this is even accurate. So I sent him for labs again because I was still distrustful of the lab and accuracy. The labs came back the same. His potassium was high. He was in acute renal failure, what I was picturing as acute. And so I immediately sent him for a bladder ultrasound. I wanted to see what in the world was causing this, because he didn't have any pain. He didn't have a kidney stone. Well, the urinary ultrasound, the bladder ultrasound that was done, found a very, very large prostate. And so what was happening was that prostate was acting like a tourniquet to his urethra, and he was able to urinate, but not very much. And that urine was building up in his bladder, and then it was building up to his kidneys beyond that. And that was causing this significant kidney damage. So I immediately sent him to a nephrology office, and they put in a urinary catheter to drain that bladder and drain those kidneys better. And so ultimately, over the span of about 6 months, he ended up having surgery on his prostate because he couldn't live with a catheter the rest of his life. So he had surgery, debulking on that prostate, and his kidneys have recovered. This is a very fantastic example of his kidneys are back up to about 60%. They're not perfect, but they're so much better than 10% when I captured it. So a very interesting story talking about that prostate and how we can have chronic kidney disease or acute kidney disease. They're very much related. When your pump is not working well, then it's not going to be able to send blood down to the kidneys and filter appropriately, and vice versa. When your kidneys aren't working well, it definitely backs fluid up and can cause fluid overload in your heart. I appreciate this picture of congestive heart failure that just gives this view of that left ventricle. We think about a muscle that gets stronger is better, but that's not necessarily the case with the muscle. When that left ventricle gets thickened, the actual pumping power gets decreased, and so we'll see fluid shifts and changes. And so sometimes it starts with the heart, blood pressure issues that end up turning into kidney issues later on. It's very much a married system. Causes. So if we think back on that picture of our anatomy and the pre-renal causes of different chronic kidney disease, volume depletion, which is dehydration, definitely can cause issues. A vascular obstruction, if we have vessels that aren't sending blood to the kidneys, then that can definitely cause a pre-renal cause of chronic kidney disease. And then one of the biggest, this is what I see in America, and one of the things I just wanted to separate for the viewers is what happens in America is not necessarily what happens in the rest of the world. I do not remember seeing the use of NSAIDs overseas that I see here in America. So thinking about Motrin, ibuprofen, aspirin, these are over-the-counter medications in America. Anybody can buy them. It doesn't need a prescription. They are often highly used. I don't want to say abused because that's kind of a harsh word to say, abused, but they are used very freely for pain management. And they're not addictive by any means, but how those medications work is it restricts the renal artery. How they work is they help with pain, but the side effect is this renal artery restriction or constriction. And so in an essence, they are hurting the kidneys over the long run because the kidneys are not getting the blood flow that they need. So I had several dialysis patients that had taken high doses of NSAID medications to manage headaches or manage muscle pain, and had resulting chronic kidney disease that actually turned into end-stage renal disease where they needed dialysis. So definitely a pre-renal cause. When somebody comes into me as a consult initially, that is the first thing I'm going to address, is we've got to stop certain medications that are nephrotoxic, that are harming those kidneys. Post-renal causes of chronic kidney disease. So these are things that happen below the kidneys. We talked briefly about prostate enlargement. We talk about tumors, bladder tumors, or anything that's happening below the kidneys. Kidney stones can definitely block and cause chronic kidney disease. So post-renal below the kidneys, pre-renal above the kidneys. Causes of kidney disease, chronic kidney disease, we've touched briefly on these. Hypertension, so anything vascular can definitely affect the kidneys. Diabetes, lupus, sickle cell, medications, repeated UTIs that damage those kidneys over the long run, and polycystic kidney disease. Talk briefly about diabetes. People will ask, what's the link here? Well, blood sugar, we should not have sweet urine. Okay, way back in the day, before we had laboratories that would tell us the glucose content in your urine, that was one of the nurse's jobs, was to taste the urine. And if it was sweet, that was an indicator that that blood sugar was elevated. So we think about sugar as being a very large molecule, and how ultimately it will damage those kidneys over the long run. So one of the biggest things we do to manage and try to prevent chronic kidney disease is make sure blood pressure is managed and make sure diabetes, blood sugars, are managed. Those are two very, very big components that often lead to chronic kidney disease. The stages of kidney disease. So on the lab report that nurses get, doctors get, even patients can look at their own lab results. It will be rated the GFR, the glomerular filtration rate. And that is how we verbalize it as a percentage. So if your GFR is 60, that means your kidneys are functioning at 60%. That's an easy thing for patients to conceptualize. If your GFR is at 30, well, then your kidneys are at 30%. And we plug those into a different stage. So I tell people, everybody has chronic kidney disease. It doesn't matter who you are, brand new babies, old people, it doesn't matter. Everybody fits somewhere in chronic kidney disease. If your kidneys are functioning at better than 90%, you are in stage 1, which is excellent. That's very few people, that's babies and children, but that's an excellent goal. Most of us are in chronic kidney disease stage 2. This is somewhere between 60 and 90%, completely appropriate, completely normal. I am not worried about this at all. When we get to chronic kidney disease stage 3, then I'm like, ooh, the antennas go up and I start thinking, whoa, what else is going on for this person? If this person is very, very elderly, I'm not worried. But if this person is young, I start questioning what is going on with their fluid status, what is going on with medications, what are we doing that's potentially harming these kidneys? Eventually, people will fall down into that stage 5, and that is actually dialysis. We cannot live very long in stage 5 because those kidneys are not getting rid of the waste in our blood, and that waste builds up and eventually causes death in the long run. So the different types of dialysis, as I round out this whole chronic kidney disease lecture and information, there are two different types of dialysis. So when we do dialysis on patients, we are replacing the filter of their kidneys that is not working well. So a very common, easy to administer dialysis is hemodialysis. Hemo meaning blood. So what happens with these people is we put very large needles into their arm, we take blood out, we filter it in a filter that looks just like a kidney, and then we put the clean blood back in. Most people in America, where I worked at least, they would come in 3 times a week for 3 to 4 hours each time to receive dialysis. Ultimately, they needed dialysis until they chose to not do it anymore, or they were accepted for a kidney transplant. Hemodialysis sometimes can happen in your home if you've got a trained family member that could help you with it, but most of the time that is happening at an outpatient center. Peritoneal dialysis, this uses the abdominal cavity as a filter, okay? So this is something that people can do at home very, very easily. They have much more freedom to travel and see many different things, many different places, family, because they're not locked into going to one center. So peritoneal dialysis uses fluid as a fluid gradient. We put fluid in to the peritoneal cavity, the patient does, and then the waste is transferred to the fluid, and then after so many hours that fluid is drained out. Difference, there are definitely pros and cons to different types of dialysis, depending on your ability, your physical function. I've had patients that do peritoneal dialysis and do very, very well, and then things change in their life. They don't have the support at home, so they end up switching back to hemodialysis. It just depends on different ways to do it. I have had some patients, though, thinking about other countries that don't have the ability to do dialysis, or the centers are very far away. I've had patients that choose to not start on dialysis, or maybe they start and they choose to stop. And I always like to touch on this for just educational purposes. It is not painful to die from chronic kidney disease. It's not like it's not that you are in pain. It's a very peaceful way to die. It's very peaceful. Well, I have been by patients' sides when they've said, I don't want to do dialysis anymore, or other things have happened, whether it's cancer or they fell and broke a hip or something, and they just said, I don't want to do this anymore. Dying is not painful. And sometimes we get that in our head that, oh my goodness, if you're not filtering, this is going to be a horrible death. And it's really not a horrible death. I've been with people in Rwanda when I was doing clinicals with students that we just didn't have the ability to do dialysis. They might have dealt with extra edema, extra fluid retention, but it was still not a painful. It was an easy way to die. It was not painful. But there are different dialysis forms. I've had patients on dialysis for 10 years. It really just depends on how well their heart is doing, how well their body is doing with the fluid shifts, how well they're tolerating things. I've had patients on dialysis for a couple of months and say, I'm not going to do it anymore. So it really depends on how healthy you are going into it. Sadly, if we've dealt with chronic kidney disease for many years, because of other issues, these bodies aren't often the most healthy bodies. And so sometimes dialysis can be more difficult because of the fluid shifts that happens. And that's all I have for this particular presentation. I know, Claude, you had some questions. Maybe I touched on some of them, maybe I didn't.
Yeah, thank you so much for the presentation, Dr. Kelly. I noted down, as the presentation was going down, I just noted down some questions So I want to pass through, like, I noted down 5 of them. So I don't know if I can pass through it and you answer at once, or I pause one, you will reply to it. Then I pause another one, you would reply to it.
Yeah, we can do one by one.
One by one, yeah. So you mentioned dehydration as the key factor in preventing kidney disease. Can you elaborate like an ideal food intake for someone with early stage kidney disease and how it may change as the patient progresses?
So I have worked with many different patients that we have chronic kidney disease stage 3. Their GFR is in the 50s, and we stop certain potential harmful medications and we focus on drinking lots of water, and we see that kidney come back up in 65%. So we move from stage 3 to stage 2 just with very simple changes. Again, the kidneys are very, very resilient, and they have a lot of ability to fix themselves if they are given the right environment. So, but on the flip side, if you continue with harmful behaviors, whether it's medications or whether it's dehydration or whether it's blood sugar problems or blood pressure problems, ultimately your kidneys will give up. They'll be like, I'm done. I can't do this anymore. So when we talk about fluid, I always like to circle back on what is the concentration of your urine? What does your urine look like? Because that will guide you the most as far as, am I drinking enough water or not?
Thank you. You're running out of time, but the next question would emphasize on, we know diabetes and hypertension as the leading cause for chronic kidney disease. What lifestyle changes could you recommend to manage those conditions and prevent chronic kidney disease?
I know we have two very, very good tools that we as patients, we as nurses, family members, we all have the ability to check our own blood sugar, and we all have the ability to check our own blood pressure. And so those are great tools that I push back onto patients and say, hey, you can check and see. Empower your patients. Us as nurses, we often take the lead and take the responsibility, and I'm going to manage their blood sugars, or I'm going to fix their blood pressure. And we can't do this. The patient is living in this body day in and day out. We have to empower them. Hey, these are numbers we're aiming for. These are what your labs show. I get very frustrated with doctors and nurses that will just tell patients, your kidneys are doing good or your kidneys are doing bad. And no, they have a brain. They can think. Tell them those numbers. Show them the piece of paper. Show them the trend. Every patient that comes into my office, I will trend out their hemoglobin A1Cs or their kidney function. Trend that out and say, wait a minute, we were doing so good here. What happened? Why aren't we doing good now? And have them be able to internally think about, wow, what did I change in my diet or change in my life that helped me or hindered me? So definitely empowering the patients it's a big thing.
Yeah. I even have experience when the patient were asked to record their blood pressure for like 7 days, come present the doctor. I think that's in a book.
Yes. And it helps you as the provider as well to say, wow, here's all of these blood pressures. I'm looking at more data than just one thing in the office. Yeah. It gives you better information too.
It can even be good when a patient takes blood pressure for him or herself, because when the patient is at a hospital or clinical setting, the environment can even give the lung.
Yep, absolutely. It can be falsely elevated. And how accurate is it if the patient's in pain or if the patient is under stress of some sort? It's not going to be the most accurate blood pressure either.
Yeah. The next question would be can you explain the common early warning signs of chronic kidney disease that patients should watch for, and how early diagnosis can change the course for treatment?
That one's very difficult because there's not a lot of signs as your kidneys don't work as well. You've got to get into that chronic kidney disease stage 4 before you start having rashes and pruritus where you're itchy in your skin. And people can be in stage 1, 2, and 3 and never know it. Never know it. They're living their life, they're doing their thing. So the blood work is one of our first clues to say, what's going on here, and how well are we filtering?
Yeah. And then to end up, I wanted to show for you, as an experienced healthcare provider across, you've been in different countries, including Rwanda, South Korea. How do the approaches to chronic kidney diseases prevention and treatment differ across those healthcare systems? Share with us.
Yeah, that's the few patients that I saw in clinical time in Rwanda. In Ngoma, we did not have dialysis options, so it was a very difficult time. And so we were with different patients that ended up going home and passing away because they didn't have that ability. When I was in South Korea, they did have the ability for dialysis, but I did not see the chronic kidney disease in South Korea that I do in America. Let's just contrast those countries, because again, I feel like South Korea, they don't take those harmful medications. I keep coming back to the medications. They don't deal with diabetes significantly. As a general rule, Asians, South Koreans are not overweight. They don't have blood pressure problems. They don't have diabetes problems as a general rule. And so we weren't seeing the chronic kidney disease as much over there as I'm seeing it here in America. Almost every patient that I see has some form of chronic kidney disease because we call it the SAD diet, Standard American Diet, SAD. It's a very, very poor diet that encompasses a lot of processed foods, leading to overweight, leading to blood pressure issues. And then, like I said, the majority of the world does not drink enough water. And so I think it's just this perfect storm. In Rwanda, Claude, you would know better. In my short period there in Ngoma, I don't know a lot of but again, we're not dealing with diabetes, blood pressure problems as much in Africa. As a general rule, I'm just saying general rule. Yes, it's there, but I did not see it as much as I do in America, for sure.
According to what I have seen, that it seems like globally 10% of the population is living with some form of chronic kidney disease or any kidney disease, often without knowing it. Chronic kidney disease is a silent killer. We do on nutrition if time allows, because I've seen that a lot of things on chronic kidney disease also comes back to the nutrition.
Mm-hmm. Mm-hmm. Absolutely. Well, Claude, it was very nice to be here, and I appreciate this opportunity. I wish the viewers to have gained something valuable for not just themselves, but their family members or their patients if they're in the nursing field, to pick up something to protect these kidneys so that we don't deal with problems in the long run.
Yeah. I think it is a good presentation. I think you